Hi there, 2020. What a year. Year of the nurse. Or was it year of the neuro-nurse? Perhaps that's going to be 2021. I'm Vicki Evans. I'm the clinical nurse consultant at Royal North Shore Hospital, and I'm also the vice president for the World Federation of Neuroscience Nurses. I'm going to talk to you today about the neurological complications of COVID-19 and perhaps what 2021 has in store for us. Hopefully it's going to be a vaccine that will be effective for all. So COVID-19, as you know, is a severe acute respiratory syndrome. It's part of the coronaviruses, of which SARS and MERS are also part of. It was first reported in Wuhan, China in 2020, and now there are over 94.7 million cases worldwide, 28,708 in Australia as of today. When I'm recording this, it's the 18th of January. And there's also greater than 2 million deaths worldwide, with 909 deaths in Australia so far. Based on other coronaviruses, including the SARS epidemic of 2002 and the MERS epidemic of 2012, the neurological symptoms in those cases were predicted to be rare. However, in COVID-19, they're now increasingly recognised. In some cases, the neurological presentations precede the respiratory symptoms, and patients with neurological signs tend to have worse outcomes. This is just a picture to show you how quickly the virus has spread. This was taken on the 20th of August last year, and we had 23.3 million cases worldwide. And today, the 18th of January, we have 94.7 million cases. So from August to January, from 23.3 to 94.7, that's a very big jump. And you can see here now most of America is covered. South America has got a lot more. Europe has taken off, and so has India. It's probably the only time I've really appreciated the fact that Australia is an island continent far away from anybody else. And with most things, you do like to see yourself on top of the leaderboard, but in this case, you don't want to be on top of the leaderboard for the global cases. And that position is the US at the moment, unfortunately, and with many, many other countries following closely behind. Many coronavirus patients are presenting early with neurological symptoms such as anosmia, ageusia, and myopathy. So cranial nerve 1, as you know, is the olfactory nerve, and the olfactory bulb is a common route for viruses to enter the brain. I'm very visual. I like to see to be able to give me a better understanding of things. So if you have a look at the picture here, you can see the olfactory tract in yellow, and look at all those little spindly things hanging off into the nasal cavity. They're the olfactory nerves. So the virus particle makes its way up the nose, attaches itself to the olfactory nerves, which goes into the olfactory tract, and then you've got a direct route to the brain. So this goes to show how important a mask is, and the nose does need to be inside the mask. Let's have a look at chemosensory disturbances. So sudden smell and taste disorders can be the first symptoms. Anosmia can precede other disease symptoms and are therefore epidemiologically relevant as an early identification of new hotspots. Similarly, the sewage treatment plants are also picking up hotspots as well. Anosmia in COVID-19 seems to be mostly temporary. If olfactory function does not return to normal within about 3 to 4 weeks, then a neurological or ENT investigation is required. Taste and smell disorders appear, especially in mild progressive disease, more often in previously healthy young people, and in women more frequent than men. One of the complications is also encephalitis. So acute encephalitis is inflammation of the brain parenchyma. It may be caused by direct infection of the brain tissue with the virus, and the virus may either directly damage brain cells through lytic replication cycles or through the cytotoxic immune response of the host organism. It usually occurs within 3 weeks of the onset of COVID, but can precede the respiratory symptoms. And there usually is irritability, confusion, altered level of consciousness, and seizures, which are common, and psychosis can also occur. No specific treatment for COVID-19 associated encephalitis exists other than high-dose steroids and or symptomatic therapy, such as anti-epileptic drugs, antivirals, analgesia, and antipsychotics. Encephalopathy is the pathological process in the brain that develops over hours or days and can manifest as changed personality, behaviour, cognition, or consciousness. Symptoms triggered by COVID-19 include sepsis, severe systemic inflammation, renal failure, and cytokine storm. It's common especially in severe cases of COVID-19 and often with seizures. They've done some studies in China which showed an encephalopathy rate of about 7% in COVID-19 patients, and that's compared to the French studies of 69% of COVID-19 patients in ICU. And I probably err on the side of the French studies. A rare complication is acute necrotizing encephalopathy, and as it sounds pretty awful, the viral particles are found in the endothelial cells and neural tissue on postmortem. So encephalitis and encephalopathy, the symptoms, neuropsychological abnormalities, agitation and delirium, extrapyramidal motor movement disorders, coordination disturbances, impairment of consciousness, seizures, and focal neurological deficits. There usually is a sudden olfactory and gustatory disturbance in about 10 to 70% of patients, and headaches in approximately 13%. Stroke is another complication. There is a dramatic increase in the number of vascular events, ischemic strokes and thrombosis, which is likely due to the virus affecting coagulating mechanisms. And that was from a report in JAMA in 2020. And they found that 6% of hospitalised patients with COVID-19 have had a complication of stroke. Most commonly, it's the large vessel ischemic events, but also intracerebral hemorrhage, and they're associated with a more severe course of the disease. The stroke usually occurs with elevated CRP, D-dimer and ferritin, or a vasculitis event. It usually occurs around day 10 following the onset of respiratory symptoms, but occasionally it precedes it. Other thrombotic events that have been found are the aortic thrombosis, limb thrombosis, and venous sinus thrombosis. All patients admitted with COVID-19 should be placed on prophylactic Clexane. So some of the case studies with regards to stroke and COVID-19, there's been several reported of ischemic stroke in hospitalised COVID-19 patients, and one is the Dutch study where ischemic stroke rates were 3 in 184 or 1.6%, in Italy 2.5%, and in China 2.8%, and another study for 5%, all done last year. All studies showed that patients with a history of cerebrovascular disease have a higher risk, 2.5-fold, for a more severe course of COVID-19 disease. Seizures. Patients with COVID-19 are at risk for acute symptomatic seizures, and maybe it's because the COVID-19 is neurotropic due to microthrombi from the inflammation or hypoxia, or excessive cytokine inactivity disrupting the blood-brain barrier. The risk is increased in patients with pre-existing neurological pathology such as multiple sclerosis, stroke, Guillain-Barre, traumatic brain injury, and epilepsy. And the Cleveland Clinic did a study on 24-hour continuous EEG on 19 ventilated COVID patients. 8 out of the 19 had epileptiform abnormalities. 3 out of 19 had electrographic seizures with no clinical correlation. All patients had a severe encephalopathy, and all patients responded well to standard anti-epileptic drugs. Guillain-Barre Syndrome. These cases have been reported in patients with COVID-19. A rapidly progressive ascending weakness, plus or minus sensory change, and areflexia. Some have the virus identified in their CSF, a definite diagnosis, or have the serum positivity, which is probable. Variant Guillain-Barre, or Miller-Fisher, is also reported. The symptoms are within 6 weeks of the onset of COVID-19 infection, either concurrent with the virus or as a post-viral syndrome. Resolution of symptoms occur with standard IVIG therapy, plus or minus ventilatory support and plasma exchange. Due to the risk of cardiovascular complications, especially respiratory insufficiency and arrhythmias, a rapid diagnosis and immediate therapy, including ICU admission, is recommended. So if we look at the picture over here, number 1, it's the hands and the feet begin to have a tingling sensation, so a glove stocking distribution. And then that progresses to muscle weakness, both sides of the body, making it difficult to walk upstairs. And within 2 weeks or so, the respiratory system could become involved. So spirometry is very important. Muscle involvement. 25% of COVID-19 patients present with a myalgia and fatigue. Rhabdomyolysis has been seen in a small percentage, but more have myositis with an elevated CK. Avoid drugs that may exacerbate this, example the statins, that might reduce the risk. And now for the memes. These are 4 that I really liked. You do have to laugh. I mean, the statistics are pretty awful. The results of some of these things, again, traumatic with everybody, the patient, the family, not being able to get on a plane, not being able to meet in person and that sort of thing. It's just dreadful. So please, these are intended as a laugh. So all I can say to you is thank you for your time. Wash your hands, social distance, wear your mask, and pray that the vaccine is available to all and is appropriate for the condition, and that we can meet again in person sometime soon. Thank you. Enjoy the day.
Yep. Hi there. I'm Vicki Evans, and I'm here today to have a little talk about Covid-19 pandemic. And I've got a few people from around the world to give us their insights as well. I've got Christy de Lemus, who is the president of the World Federation of Neuroscience Nurses. I've got Neil Cook, who is the president of the European Association of Neuroscience Nurses. And I've got Charmaine Arulvaradhan, who is the Treasurer Secretary of the World Federation of Neuroscience Nurses. So I'd like to welcome you all. Thank you for getting up or staying late, whatever time it is in your neck of the woods. As you know, COVID is obviously a pandemic. It's hit the worldwide stage, and it's making its mark everywhere. And I'm just going to share a screen with you now to show the impact of COVID worldwide. And you can see there, unfortunately, we're about to hit the 100 million cases worldwide. And Christy, I'm sorry, but the US is on the top of that list with the death toll. And further down the track is all the countries listed. And, Australia has only got 909 deaths so far, but we're not out of the woods. And this is the one time that I'm glad that we're actually an island continent far away from the rest of the world. I'll stop sharing that screen now, and I'm going to hand over to Christy. Christy, you're from the US. So what's it like there with COVID in the US?
Well, I can tell you at the beginning of the pandemic, it was a bit like flying the plane while we were assembling the wings. So we really had not seen, nor were we equipped to deal with something that was spreading so quickly, and looking for ways to really manage bed availability and to inform the public about the risk. There were many US citizens who unfortunately did not believe this was as serious as it was, which resulted in it spreading very, very quickly. And you can see that amongst the communities in New York, where mass transit was available and people continued to crowd into buses and the commuter systems, and this spread very, very quickly, overwhelming our healthcare system. We did here in California pretty well at controlling case counts until more recently. So in October, we had 4 cases, and we were actually quite pleased. It had been a hot summer, and then by mid-October, we could see that the case counts were beginning to climb, and then they were as high as 110 in the hospital, requiring ICU or significant medical surgical care more recently. So it's been a very, very tricky last couple of months before the vaccine was available. And so, it's really pushed all of our resource. As far as our nursing, we've looked at, it's about a bit like Apollo 13. We asked ourselves not what does this thing do, but what can it do? And we looked at every single resource and tried to use our nursing resources in different ways than maybe we originally thought. We had some nurses working as nurse consultants or nurse specialists who were also licensed as nurse practitioners. We quickly changed their role to working as a nurse practitioner so they could provide direct care to patients and help us alleviate the workload that, in managing our patients. And we wanted to still provide that same high quality care that our patients expect. So it was a tricky time for us. Now that the vaccine is here, I can say that there's a real sense of renewal and hope that maybe that we're going to get this behind us, and we'll be able to return to normal. We've administered about 14,000 vaccines at UC Davis to date, and are hopeful that we're headed in the right direction with our case counts.
Right. Okay. And you're sitting there in your office, yet you've got your visor and your mask on, and no one else is in the room with you?
Yeah. So a
Yeah.
little bit about our safety measures in at UC Davis. And unless I am in an office with the door closed and absolutely no one with me, I must wear all of this. I'm in clinic today seeing patients. We also cannot eat together. That's completely been banned. So if I have a colleague who wants to have lunch, that's out. We can't share any food. So there's no food that's not individually wrapped, and we can't share office space. So it's unless you have all of this on in the office space itself while you're working. Wow. So there's definitely been a crackdown on making sure that we're taking all protective measures to try to avoid spreading this further. Just really, really interested in preventing more cases from occurring, and particularly transmission from healthcare providers. At one point, we had 220 healthcare providers out with COVID. We are now down to 28. So we're going in the right direction. So all of this is making a difference.
Yeah, of course it is, yeah. So social distancing, masks and hand washing. It's interesting though, with all that being brought in on top of us, the rates of just the flu is minimal. So had we been doing that earlier on, maybe the flu would have been not less of a problem. Neil, how's things over in Ireland?
So I'm suppose uniquely situated on the border between the Republic of Ireland and Northern Ireland, and I work in the UK, so I have a UK perspective and a Republic of Ireland perspective. From a UK perspective, I think particularly for Northern Ireland, we managed the first wave of the pandemic really well and had very low numbers. We stopped all non-essential or non-acute admissions to hospitals, so no elective admissions at the time. And in nurse education, we redeployed all of our final year students in to practice on contracts and our second year students to support the workforce, which worked very well, I think, to ensure that we had sufficient numbers on the floor. We still were able to support our students to complete, and that was a UK-wide approach. That was through the 4 chief nursing officers for Northern Ireland. And while it was particularly difficult in London and some of the bigger cities, we managed the first wave quite well. In the most recent months, particularly in the run-up to Christmas, and now it's a much different story, and it varies greatly across the UK. In England, it varies a lot, but in some places, the army have been drafted into the hospitals. Some police force had been redrafted to be ambulance drivers. In some areas, they've removed all the students out. Other areas, they've mobilized students back in again into the workforce. Some areas, they've suspended their programs. It varies as you move region by region, and obviously this new strain of the virus has obviously exacerbated matters, and so we're seeing quicker transmission, larger numbers coming in, and in some places the services are overloaded. And so what we are seeing is, for example, in neurosurgical wards, no elective surgery, less trauma because we're still in lockdowns, so you're getting maybe less of those traumas in, and then having to readapt to manage the flow of patients that are coming in. So most areas, most surgical wards, for example, are closed and have become medical wards and respiratory wards. So nurses have had to adapt regardless of their specialty, and have had to upskill in a number of areas. We have had one of the earliest rollouts of vaccines, which has been rolled out to healthcare workers and the older vulnerable population quite well. Really good, I suppose, system and approach for getting that, and redesignation of staff, very similar to what Christy has talked about in terms of people's roles being changed and people being redesignated and retrained into roles where they can help, even if it's vaccination clinics or into less higher dependency wards, to move the people in those wards up to higher dependency areas. So they've kind of scaffolded some of that training to maximise the response to the service. The Republic of Ireland has seen something similar in that the first wave was quite well managed. I don't think we ever maxed out the bed count in the hospitals at that time. It's now reaching capacity at the minute, also in a lockdown, so people can't really move more than 5 kilometers from their home without particular reasons, which are very, very few. So people are very isolated. I think one of the things that we have not yet really seen the full impact on is the mental health issues to do with isolation, but also the mental health issues of the staff that are quite clearly traumatized. I think, like Christy said, it's a bit like building the road while walking it. So we're learning as we go. And that has been a challenge for staff and the pressures for staff. So we have a lot of staff sickness and a lot of staff shortages, which means that there's huge pressure on the staff that continue to go in. But at the same time, there's a huge collective resilience, and nursing has never been showcased more for how much nurses step up in times of adversity to really deliver for the public, really showing how selfless nursing is. And even, you know, nearly a year into it, that's still the case. So still very challenging times. Numbers are starting to drop quite well at the minute, and I think we're close to 10% of the population having had their first dose of vaccination in the UK. Republic of Ireland, not so lucky yet in terms of delays in supply of the vaccine. And then there's all the challenges that come with a border between Ireland and the UK and Northern Ireland, and different systems of managing the pandemic and cross-border workers and things like that. So there's still a lot of challenges there. So it's been a tough year. I think it's probably at the toughest part of that year in recent months.
So, yeah, very interesting. All you guys have started your vaccines a little while ago. Australia's getting our vaccines probably at the end of February, and we'll start and see what happens there. So, Charmaine, what's the Canadian perspective on COVID?
I think we share bits from what each Christy and Neil have both shared. The first wave hit our long-term care centers and our seniors the hardest. And the reason for that being that our system is privatized as well as public. So there are different standards between private centers. So the supplies of PPE that they stocked were different, and their IPAC procedures were different depending on facility. That made a large difference in how the virus was able to spread. So our seniors have taken the brunt of the hit with the pandemic. And then our second wave seemed to pick up around the holidays. So it began around September and it peaked just 2 weeks after Christmas. And we seem to have come down after that. As far as what patients have been affected worse, we're seeing our neurosurgery services scale down. There's capacity in their services just recently. So we were operating at 100% capacity until about 2 weeks ago, and we made the decision to go down to about 30%. And our stroke patients actually are experiencing a bit of a hit as well. I heard one story last week where a patient phoned in to our TIA clinic, letting the nurse practitioners know they think they had a stroke, but they fear coming into the hospital and getting COVID, so they're going to stay at home and not get treatment. So that is an example of public perception, as Christy was saying, is difficult to overcome, but as well, a public that just seems to think that COVID has infiltrated our hospitals and is everywhere. In reality, we're not experiencing as many outbreaks as the public do probably think we are experiencing. So our hospitals haven't been badly affected in terms of outbreaks. There have been some interesting strategies for managing the increased bed capacities that are required. So our pediatric units at various hospitals have all consolidated into one Hospital, so the Hospital for Sick Children in Toronto, to free up adult beds. So pediatric patients have all been centralized. And in turn, we've also been sending patients from inside the city, outside to the outer hospitals as well. So there have been movements. I think they moved something like 400 beds 2 weeks ago to make space in the inner core to be able to treat the COVID patients.
Yeah, a lot of infrastructure, a lot of issues with PPE in the beginning, although I think that's sort of petered out now. We have enough toilet paper for everybody. Although I did notice on our news last night that a truck carrying a whole lot of toilet paper burst into flames on the highway. So that's all gone. But anyway, I think everything's good. So has there been an impact as far as like neuro complications from your COVID patients? Have you seen, increased strokes, encephalitis, Guillain-Barre, those sort of things because of the clotting mechanisms? Anybody seen that?
I can speak for the U.S. and I don't think we've seen clear correlations between an increase in stroke, although people are deferring care, and I think that's impacted neurological disease. Patients with MS not coming in to get their treatments, their infusions, and then having exacerbations because they're concerned about exposure. So I think that's been where we've seen stroke, and also delays in care, like Charmaine was describing, where people are too fearful to come in for a neurological complication. So then they go on to have a full-on stroke. Maybe they have a TIA a week ago, and previously they might have reached out and been seen for that, but now they just waited. And unfortunately that waiting resulted in them having a full stroke because they were never treated appropriately.
Mm. And how, has anybody got any comments with regards to the way they practice, more telehealth, that sort of thing? Has anybody been involved in that? I know for here, we're doing a bit more telehealth as far as pre-admission patients. And Christy, you're showing me something there?
So we actually completely converted them in the clinic to telemedicine.
Right.
And so our patients that are coming through are being given this flyer saying, let's change to telemedicine. And I'm not sure we'll ever go back. We actually started doing video visits for follow-up for aneurysm treatment, for anything where, there was we used a lot more absorbable suture instead of, because I work in a neurosurgery practice, than our normal suture material. And we really have converted post-operative visits to telehealth visits. And so, we're even doing consults that way. It may seem very strange, but all of the radiology can be sent electronically. And we see brain tumor patients now via telehealth and do the majority of the workup remotely, knowing that we're looking, our neurological exam is not as good as it would have been if it were in person, but you can certainly see a facial weakness. You can see someone having an extremity drift. There are things you can see.
Squeeze my fingers.
And have a pretty good sense of what their neurological deficits are. The other thing that I think is interesting about converting to telemedicine is we're learning a lot more about the social determinants of health. So for example, I had a patient that I was seeing for a brain tumor, and we were going to do surgery on her. And during our telehealth visit, she had these 6 cats that were circling her head and laying down on her. And I'm thinking, holy cow, we actually do need to think about the cleanliness of the incision. We need to talk about making sure that someone's there to care for the cats after she has her surgery, so that we can make sure that she's safe after surgery and that her animals are well cared for. But it isn't something that I would have even been aware of had I seen her in the office.
True, yeah. Neil, any lasting comments?
No, I think that I suppose time will tell. I think around stroke, I think that maybe some anecdotal information is that there's a lot of people displaying some symptoms of stroke before death, particularly in some younger people. But I suppose it really depends on the data that's being collected on those deaths and how those deaths are being recorded for us to tell that in time. So I think it's an emerging picture in terms of those elements, and I do agree with Christy in terms of those social determinants. I think are becoming you know, much more forefront in terms of, well, what is the social context the person is living with? Do they live remotely? How accessible now are services when they go home? How easy is it to get support? You know, a lot of people who would have worked in community support roles for agencies maybe are actually caring for their own family. There's less people available for that. So it's making us think maybe a little bit more holistically and more person-centered, and that's positive learning for us.
Yeah, I think you're right.
You know, to think about those things.
Mm. And anything lastly from you, Charmaine?
Just that there is emerging research about this, and this is so interesting to kind of see the sort of benefit that we're kind of realizing through the vaccine research and what that can do for cancer therapy. There is one article that's put out by two of our neuroradiologists, Dr. Nicholson and Dr. Krings, and that was put out last year in 2020 in August in the neuroimaging findings in patients with COVID-19. That's the name of the study. And it was connecting the virus with evidence that there is observed internal bleeding and clotting in the blood vessels of the brain for patients with COVID-19, and that it could be related to an infection of the blood vessels like an endothelialitis. And so it's just a case account of four patients. I believe 3 of them were on ECMO, but it is an interesting read, and it's going to be fascinating to see what kind of research comes out in the future around this.
Yeah, it's all starting to come out now, isn't it? Clotting and that sort of thing. Yeah. Can I thank you all for your time? And this will be put into the symposium, and I'll speak to you guys soon. Thank you.
Take care, and thank you for the opportunity.
Thanks.